Hello and warm welcome to Pediatric Orthopedic Advanced Learning Session. Today is the 60th session. We are very fortunate to have Dr. Pieter Mare from South Africa, and he's going to speak on a topic which is very close to his heart. Dr. Pieter Mare is the head of Pediatric Orthopedic Unit at Gray's Hospital, a tertiary referral center in South Africa. He has extensive experience in deformity correction with a particular focus on surgical treatment of Blount disease. And that was also the subject of his PhD thesis. He's actively involved in postgraduate training and the research supervision. Outside the field of orthopedics, he enjoys life by spending time in ocean, exploring the oceans and mountain of his area, that's the KwaZulu-Natal. We are also very fortunate to have our own Dr. Vidyasagar Chandankere, who also have published a lot on Blount's disease. That is definitely much less than our expert speaker, but Dr. Vidyasagar also has extensive experience for the Indian context, and he's going to manage the question answer session after the lecture. So with that, I hand over to Dr. Pieter Mare.
Thank you very much, and thank you for the invitation. So good evening, everyone, and thank you very much for giving me this opportunity to share our experience in treating Blount's disease. My goal today is to offer for you a practical framework to help guide your surgical decision-making for this complex and highly variable condition. You can see that's South Africa. I'm from the East Coast there, where you see the little airport with Durban. If you zoom in, you can see about an hour inland from Durban is a little town called Pieter Mare, and that's where I practice at a hospital called Gray's. Those are my financial disclosures, and I'm affiliated to the University of KwaZulu-Natal. So Blount's disease, or tibia vara, describes a condition of abnormal growth that affects not only the physeal plate, but also the epiphyseal cartilage, the osseous center of the epiphysis, and the metaphysis. Now, this results in a complex three-plane proximal tibial deformity, and that goes together with associated compensatory deformities of the femur, the distal tibia, and potentially the subtalar joint. We know that etiology is multifactorial, but excessive mechanical force definitely plays a role. Now, Frost expanded on the Reuter-Falkman principle with his chondral growth force response curve. And this essentially means that mild compressive and tensile forces will stimulate growth, whereas excessive or prolonged forces will inhibit growth or even may cause growth cessation. And that would explain why a child who presents to us with mild physiological bowing, the deformity is likely to improve, whereas if the child has excessive physical bowing or obesity accompanying this deformity, the forces exceed the threshold, and these are likely to progress to Blount's disease. Obesity on its own is also closely linked to Blount's disease. We know that children with Blount's are more likely to be obese than their unaffected counterparts. Children with physiological bowing who are obese are more likely to go on to develop Blount's disease. And the magnitude of deformity is also associated with the extent of obesity, and obesity in itself is a risk factor associated with recurrence. This, however, doesn't explain why we still get unilateral Blount's disease or sometimes severe Blount's disease in children who have normal bone BMIs. So we know that children with Blount's present on a spectrum of deformity, and that's because there's a different osseous response to the mechanical stress, which is dependent on the degree of ossification, which in turn is again dependent on the age of the child, obesity and the hormonal environment, and as well as the stress that the bone is under. Now, this has resulted in the classic age-based classification system of Blount's disease, which varies from infantile to a late onset Blount's disease. And I've put those images there just to show what a spectrum of disease these children can present with. Now, the image on the left there is of a 3-year, 2-month-old child with infantile Blount's disease. The central image is a child with infantile Blount's disease as well, so it started early, but the child presented to us late, and you can see the advanced distortion of the epiphysis and the metaphysis and the severe downsloping of the medial plateau. And the image on the right is late onset Blount's disease with much less extensive or severe dysplasia. In neither of these images do we see a distinct bony bar, and that's been our experience as well. Mostly these children that we see, they don't have a distinct bar until close to skeletal maturity, and it's rather a condition of growth suppression rather than something that's easily addressed by excision. Now, knee instability in association with Blount's disease is well known. This was originally described by Blount in his 1937 paper. The first medial elevation osteotomies that I came across was from Langenskild in 1964, but it's really Siffert and Cutts who defined it when they inspected the medial plateau at arthrotomy when they did concomitant metaphyseal corrective osteotomies. And they described this medial defect when the medial femoral condyle engages with a defect in 15 to 20 degrees of knee flexion. Then MCL then becomes lax and the knee is unstable. They also found an associated hypertrophied medial meniscus. So this is really going to come into play later on when we need to select the optimal surgical strategy to correct the deformities here. So when a toddler presents to us with lower limb bowing, we have to consider the differential diagnosis. It might just be an immature gait pattern with externally rotated lower limbs with knee flexion. Alternatively, physiological bowing is more important because it's indistinguishable from Blount's disease before the age of 36 months. The radiological characteristics of physiological bowing is diphyseal cortical thickening of both the femur and the tibia, together with distal femur and proximal tibial metaphyseal beaking, and triangular epiphyseal ossification centers of the distal femur and the proximal tibia. And that's a very classic example that you see in the x-ray there. And this child went on to completely remodel with a normal mechanical axis without any intervention. Now, lastly, pathological bowing. In our center, Blount's disease is the most common cause, but you have to consider other causes as well. So rickets, skeletal dysplasias, focal fibrocartilaginous defects, post-trauma or infective changes should all be considered. So how does infantile Blount's disease differ from this? The deformity is progressive. It doesn't improve with time. It's isolated to the proximal tibia. And the classic radiological features, which were described by Langenskild to occur by the age of 36 months, are apparent in this image of a child who is 44 months old. You can see there's a medial metaphyseal lucency, there's sclerosis, and there's fragmentation and delayed ossification of the medial aspect of the proximal tibial epiphyseal ossification center. So, if you're still uncertain in differentiating between physiological and infantile Blount's disease, there are some measurements that can help. Now, these are by no means the only measurements, but they're the ones that I found the most helpful. This is the metaphyseal diaphyseal angle described by Levine and Dhiren in 1982. But it was Schoenecker who defined or refined the criteria for physiological bowing and Blount's disease, with the range being less than 9 degrees indicating physiological bowing and more than 16 degrees indicating Blount's disease. Between 9 and 16 degrees, there was an unacceptable false positive or false negative rate for greater than 5%. And it is in that intermediate group that the epiphyseal metaphyseal angle, which is the image on the right there, with a cut point of about 20 degrees, become helpful in differentiating between the two conditions. Now, the radiographic features of late onset Blount's disease are much less severe. Thompson and Carter subdivided this into two groups, with juvenile being of age at onset between 4 and 10 years and adolescent after the age of 10 years. The X-ray features are less severe. There's maintained medial ossification without a severe medial articular depression, and there's narrowing of the medial physis that is visible. The clinical examination is really critical. We need to correlate the X-ray findings with our clinical evaluation because it's so easy to get these wrong. We need to examine the tibial deformity also with the patella facing forward. It's not only when we're taking the X-rays that this is important, because otherwise the child will lie with the limb in external rotation. We will basically be assessing the limb in the deformity in the oblique plane. So we'll be overestimating the amount of varus and underestimating the amount of procurvatum. The second reason why we often underestimate the procurvatum is because of compensatory knee hyperextension that masks this bony deformity. Internal torsion is assessed by the intermalleolar axis, and medial joint depression is examined by looking at knee instability, which is checked both in 15 to 20 degrees of knee flexion, as well as in full extension. And with advanced instability, it may be knee instability may be visible as lateral subluxation during the stance phase of gait. Now, associated femoral internal torsion or increased femoral anteversion has also been described in association with Blount's disease. So therefore, we always check, excuse me, the internal external rotation range of the femur. Just pay close attention to look at the interepicondylar axis rather than using the tibia as a surrogate. Because of the tibial deformity, you'll get false readings. And you have to look at the ankle and subtalar deformity, subtalar valgus. You need to make sure that subtalar valgus is correctable. Otherwise, that needs to be included in your surgical treatment plan for this patient if it has become fixed. We quantified knee instability by classifying it as follows, with grade 0 being no instability, which very seldom occurs, grade 1 being stable in extension and unstable in 15 to 20 degrees of knee flexion, and that's the typical Siffert-Katz instability. Grade 2, the knee is unstable in full extension as well, so there's a degree of lateral attenuation as well as medial joint line depression that exceeds the threshold. And then in grade 3, in addition to being unstable in full extension, there's also the lateral thrust, which is observable during the stance phase of gait, or maybe measurable on the standing AP X-ray. And that is a X-ray example just showing that. X-ray classifications, there are several known. The best known one is that which was described by Langenschuld originally in 1952. Incidentally, he didn't intend it as a classification system, but rather as a description of the progressive radiographic changes that the child with Blount's disease undergoes with time. However, it's been used as a classification system, and also it's been used in an attempt to predict recurrence risk. Unfortunately, there are some problems with inter-observer reliability in the intermediate grades, which is also where the threshold is for predicting recurrence risk. And therefore, there are several other classification systems that have been developed, like the Leville or Catenay, who developed the Fort de France classification, which also includes an assessment of physeal perfusion on MRI. And more recently, the Lamont classification have tried to simplify it into 3 grades, A, B, and C, with the distinction being the morphology of the metaphyseal defect. Now, in Lamont's work, the grade C is more likely to go on to recur, whereas the grade B's have a lower recurrence risk. And the difference between the two is that the shape of the metaphyseal defect in the B's have a ski jump or a playground slide type appearance, whereas in the grade C, it's a steep down sloping deformity. Now, I'll get back to this in a moment. So why do we look at recurrence? Why is it important? It is the most common complication of the treatment of Blount's disease, with the range being from about 30% to 70%, depending on what patient cohort you're looking at. And the reason why it's important is because the only long-term studies that we've got show that the factors that correlate with symptoms at skeletal maturity are both recurrence and repeat osteotomy. So which factors predict recurrence? We know that the age at osteotomy is important. It's quite a wide range in the literature, but most authors agree it's age at osteotomy after the 4th year, the risk starts going up. Obesity and magnitude of the deformity as measured by the tibiofemoral angle have also been shown to be associated, as well as Langenschuld stage greater than or equal than grade 3 or grade 4. Lamont C, as we've discussed, and then I want to stand still for a moment on the medial physeal slope, abbreviated as the MPS. Now, this was originally described by Kling in 1990 as an angle measured between a line drawn parallel to the lateral physis and a line drawn parallel to the medial metaphyseal defect. Now, he reported a value greater than 60 degrees being predictive of recurrence. When we looked at the recurrence rate in our patients, we found that it wasn't always easy to do this measurement, and we had to find ways to get around that. One way is when the metaphyseal defect is at an oblique plane to the X-ray, we ended up with this oval shape, which we then traced and drew the line B, which is a line bisecting it, and measured the angle X there as the MPS. The second difficult scenario was when there was lateral physeal widening, and we decided to measure it on the metaphyseal side of the physis to not underestimate the extent of the deformity. So we looked at 35 limbs in 20 children, all under 7, treated with a curved proximal tibial osteotomy corrected to physiological valgus, and we found a recurrence rate of 40%, which seems to be comparable to the recurrence rate in the literature of a similar patient group. Now, what we found was corroborating what was already known, that the Langenschuld stage, the deformity severity as measured by the TFA, and the MPS all predict recurrence. We also found that our instability classification was able to predict recurrence. It's associated with recurrence, should I say, at least. So our aim with this was to try and build a model through which we can predict recurrence. But when we did a multivariate logistic regression analysis, we found that the MPS in isolation was the single best predictor of recurrence. ROC analysis confirmed Kling's work that 60 degrees was the optimal cut point for this as a predictor of recurrence, with high sensitivity and specificity and an excellent area under the curve of 0.925. So this really is the way that going forward, we've predicted a recurrence risk in our surgical treatment selection strategies. Before we go on to treatment, I just want to stand still for a moment. You have to do multiplanar deformity analysis when we see these children, because they can have a lot of associated abnormalities. So we quantify the deformity by measuring mechanical axis deviation, look at the proximal tibial varus with the MPTA, the lateral distal femoral orientation. Knee instability can be measured by looking at the joint line congruency angle, and the procurvatum, very importantly, is measured by the PPTA. And then we need to look at the ankle with the lateral distal tibial angle, and also at the hip at the neck shaft angle. The subtalar joint is not here, but that's a clinical evaluation that you need to make. So what are the aims of treatment? We want to correct alignment in all 3 planes. We want a stable knee. We want to try and mitigate recurrence risk while considering medial growth potential. We want equal leg length at maturity, and we want to try and avoid unnecessary repeat osteotomies. And how we're going to achieve that is a wide range of treatment options. It can be guided growth, osteotomy and acute correction, or osteotomy and gradual correction for that matter, medial elevation osteotomy, lateral epiphysiodesis, temporary or permanent, a combination of these procedures, and if we're combining them, we can do that staged or we can do that simultaneous. So it can be very challenging to develop a coherent treatment strategy that you can clearly tell the patient and understand what to expect. So for the rest of the talk, what I'm going to do is just touch on each of these treatment methods and try and give you our approach, and also present to you the evidence that supports that and the results of that treatment in our center. So guided growth is a very attractive option. If you look at that timeline, that's PubMed, looking at papers discussing guided growth and Blount's disease from 1944 to 2025. So in the last 20 years, multiple papers have come out. However, the results vary quite widely. In combined groups of both infantile and late onset Blount's disease, the efficacy range from about 40% to about 80%. Some predictors of failure have come to the fore, so deformity severity goes without saying, obesity, Langenschuld stage, and age. Although some authors have reported better results in adolescent Blount's disease, and some authors have reported worse results. And so we really don't know which are the optimal patients to treat with this modality. We looked at our patients retrospectively. So you must understand that this is retrospective, so you can take these values with a pinch of salt, but I think it is a good guideline. So in infantile Blount's disease, a TFA less than 30 degrees, these are all anatomic measurements because we didn't, unfortunately, have long leg films available for most of them. So we had to rely on that. A Langenschuld stage less than or equal than 2, and an instability in our classification system of less than or equal to 1. So in other words, no knee instability with a knee fully extended. And in late onset Blount's disease, the TFAs were all less than 20 degrees, and they had more than 2 years of growth remaining. Importantly here, when we're doing guided growth, you need to look at the distal femur and just address that at the same time, because we don't want to end up with joint line obliquity at skeletal maturity. So what were our results? The guided growth, the tension band plate, was able to correct deformity in a high proportion of cases, 78%. However, we weren't able to translate that into normal mechanical axes, and mainly the reason for that is at the bottom there you can see those 2 overcorrections, unfortunately. So it goes without saying, these patients have to follow up. You have to see them in time, otherwise you're going to overcorrect them. Our overall success rate in infantile Blount's disease was 57%, and in late onset Blount's disease it was 73%. Now, how does this compare to bigger studies? And these are multi-center studies. The one on the left there, published by Dhiren et al. In 2020, found a relatively similar success rate for infantile Blount's disease of 64%, and also a better success rate in adolescent with 88%. I really like the work by Walker et al. They published quite a few papers in 2023 looking at guided growth in Blount's disease. And in infantile, they tried to look at which are the predictors of failure. In infantile Blount's disease, it appeared that a mechanical axis deviation greater or equal than zone 3 predicted a failure, as well as a MAD greater than 40 millimeters as an absolute measurement. So that was associated with treatment failure. However, all children with a mechanical axis deviation greater than 80 millimeters ended up to have treatment failure. Weight greater than 70 kilograms in the infantile group, and then in the late onset Blount's disease group, the magnitude of deformity once again, but not stipulated exactly how much, weight greater than 100 kilograms, and proximal femoral physeal closure as a surrogate for skeletal maturity. So when we read all these papers of guided growth in Blount's disease, most of these authors will make a statement along the lines of they think it's, they advocate the treatment, they think it's effective in many cases, and that even if it fails, you may effect some deformity correction with very little harm. Now, in most cases, I think that's true. However, I do think there are some caveats, and I'd like to share with you when I would avoid it. So, infantile Blount's disease close to 4 years. Now, to me, the aim should still be, as it always has been, to correct the deformity by the age of 4. So if I feel that I'm not going to affect deformity correction by the age of 4 with guided growth, knowing that it's going to take some time, going to correct between 1 and 1.5 degrees per month, depending on the growth velocity at the time, I would rather go and do a tibial osteotomy and correct the deformity immediately. The second group is infantile Blount's disease when there's already knee instability in full extension, so grade 2 instability. And that means that is just purely because of the extent of the growth inhibition has already resulted in articular distortion. If you leave these children with an 8 plate there, they're just going to get progressive lateral ligament attenuation. It's very unlikely to correct the deformity, and the lateral 8 plate may even cause a pagoda type deformity and add to the increase in the angle between the medial and lateral tibial plateau. And lastly, in late onset Blount's disease, when the deformity severity exceeds the growth remaining, when weight greater than 100 kilograms is relative, and then also knee instability. And I've just put this picture here to show you, this is a child who presented to us at the age of 10 with classic Blount's disease on the right, more sort of looks like a juvenile Blount's disease on the left. There's also some distal femur deformity, which you can see there, but the striking thing here is the lateral joint line congruency angle, and you can see the significant ligamentous laxity. So certainly don't want this child to walk around like this for another year to 18 months. So we opted for acute correction here. So that's guided growth. Moving on to what was previously known as the gold standard and is now under contention from the guided growth group. That's osteotomy and acute correction. There are many different osteotomy techniques described. No technique is superior to another. We use the classic curve technique, which was, according to Langenschuld, described in 1929. That's the one in the image on the left there. And we can discuss the various aspects of it, but there are still several decisions that you have to make when you decide on an osteotomy. It's not only the osteotomy type, also what incision are you going to use? Are you going to fixate it? Are you going to do acute versus gradual correction? And what are your correction targets? So just sharing with you what we do is an oblique incision from proximal medial to distal lateral. And the reason for that is that if there is recurrence, we can just extend that same incision proximally and do a medial elevation osteotomy at the second procedure. On the right there is the fibular osteotomy, which we do in the middle third. Now, the reason for that is because that avoids the nerve to EHL, which is the most common complication in our hands, and it also stays away from the peroneal tendons more distally. So that's our ideal location of the fibular osteotomy. So what are our targets? We'd certainly want to avoid undercorrection, and that's borne out in the literature. We aim for physiological valgus between 0 and 5 degrees of mechanical valgus. Some authors advocate overcorrection, and that means that you aim for more than 5 degrees of valgus in the hip-knee axis. Late onset Blount's disease, most authors advocate a neutral mechanical alignment, so that's a 0-degree hip-knee axis. The complications of Blount's disease, osteotomies in Blount's disease. Now, the most common one is obviously recurrence, but the second most common one is peroneal nerve injury, and that is up to 21% in some series. We see it quite frequently, probably in the range of 10 to 20% as transient weakness of the extensor hallucis longus. In most cases, this resolves, but in some cases it does persist. And that's why we try and stay away as much as we can from the proximal third of the fibula. Compartment syndrome and arterial injuries are catastrophic complications, and we have to discuss this with our patients and take great care when we're performing these procedures. If you do enough of these osteotomies, unfortunately, you will see it. We try and avoid compartment syndrome by doing prophylactic anterior fasciotomies, always use closed system suction drains, and we are meticulous about elevation. We want to make sure that the patient's limb is elevated from the post-operative bed to the recovery to the ward. It's that first 24-hour period. If the anesthetic team elevates the end of the whole head of the bed to try and prioritize the airway, blood is pooling in that limb, and you may predispose this child to a compartment syndrome. And that's an example. So that's a young child. She was 7 at the time, had a medial elevation osteotomy combined with metaphyseal osteotomy, and developed a compartment syndrome at 36 hours. Fortunately, she kept her leg, but she has a persistent foot drop. And you can see she had multiple surgeries, ended up with chronic osteomyelitis, which fortunately is quiescent at the moment. So always bear this image in mind when you're doing a tibial osteotomy. These procedures are not without complications. Delayed union and non-union are not really seen in young patients who have proximal tibial metaphyseal osteotomies. So how can we try and mitigate this recurrence risk? Overcorrection is one approach which we've mentioned, although the evidence doesn't really bear this out. A study by Shabana et al. 2014 showed no difference between the limbs that were overcorrected and those that were corrected to physiological valgus. The medial epiphysiolysis was popularized by Andrade and Johnston from Texas Scottish Rite, and while they've shown some promising results, the pathology doesn't really lean itself to that kind of procedure because there's no distinct bar and the results have not been uniformly replicated. The third option is a lateral epiphysiodesis, which we really can only do permanently if we have ensured that there's no medial growth potential left, or if it's close to skeletal maturity. And that leaves us with only one other option, and that's temporary hemiepiphysiodesis. So we tried that, guided growth as an adjunct to tibial osteotomy to try and decrease the recurrence rate in children who are identified to be at risk for recurrence. So that in our practice is children with Blount's disease with an MPS greater than 60 degrees. So in 22 limbs in 14 children, we performed this procedure. Now the recurrence rate was still extremely high, 77%. We had 2 cases of 8-plate failure that might have contributed, but not that much. When we compare this to a historical control group of matched children with also an MPS greater than 60 degrees, we've found only 12 limbs in 8 children. However, the recurrence rate there was 92%. Now, this difference was not statistically significant. So the jury is still out whether this may be an effective technique for a subset of children. Which ones they are, we don't know. And is there potential for problems? Yes, potentially there are problems. If there's no medial growth that resumes, you may create that pagoda type of proximal tibia. So if you do this, you have to monitor them closely. And once you see that developing, immediately abandon, complete the lateral epiphysiodesis, and do a medial elevation at the same time to correct the morphology of the articular surface. So this is just a case example of a child with infantile Blount's disease. You can see this, the MPS there is about 80 degrees in the image on the left. Then the post-op is the image on the second to left. You can see there's a dome-shaped or curved osteotomy, the 8-plate, the guided tension band plates in situ there. You can criticize us that we've slightly undercorrected it, and I won't argue with you. But despite that, you can see that the limb is corrected in the third image from the left, and then on the right, after removal of the tension band plate, the mechanical axis as normalized. So this is something that is ongoing work. Now I'd like to move on to late presenting infantile Blount's disease. Now, these children may present late because the caregiver hoped that the deformity will get better on their own. They might have seen siblings or other children with physiological bone that resolved and were hoping for the same. Or alternatively, it can be due to recurrent deformity after previous metaphyseal or realignment osteotomy. Now, the defining characteristic of a late presenting infantile Blount's disease in my practice is that of a quantifiable medial plateau depression. They may have associated lateral ligament attenuation, and if it's left for a long time, they will have lateral tibial subluxation also during the stance phase of gait. And you can see that medial depression with the predominantly cartilaginous proximal tibia on arthrogram in the image there. So we have to quantify this, both in the clinical evaluation of the knee instability that we grade, and then also a radiological assessment of the medial depression. Now, you can do this with an MRI if you have that available. Unfortunately, we don't have that available for most of our children. So we do an arthrogram at the time of surgery, and we've quantified this as looking at the angle of depression of the medial plateau on the left, and that looks at just the osseous component. And then if you look at the arthrogram angle of depression of the medial plateau on the right, you can see that the true depression is much less than what it appears due to the delayed ossification on the left. So you have to really consider this when you both when you're treating these patients and when you're assessing the X-ray results of your elevations. It's not only the magnitude that's important, but also the orientation. And Abraham et al. Showed that these medial depressions can be purely medial, or they can be almost purely posterior, or anywhere in between. So we need to be careful when we look at that when we plan our elevations. So when do we do medial elevations? When there's knee instability, at least grade 2. Age at surgery, at first presentation, generally from the age of 6 years. But from the age of 5, if the child's already had a recurrence, so in other words, we've established that there's no or very poor medial growth potential, and then you have to quantify that there is a true depression of the medial plateau, and we do that with an arthrogram, and we're looking at about at least 30 degrees. Now, I haven't found any normal values, and that's something that we need to look at as well, as a reference for us to indicate what is pathological. So our surgical approach starts with the lateral epiphysiodesis because these children have very poor medial growth potential, and this is not a physeal sparing procedure. So in other words, if there was any little bit of growth potential left with this elevation, we're likely to damage that. So we have to do a lateral epiphysiodesis at the same time so that we don't sit with a recurrent deformity. The medial elevation is done, as you can see in the image on the left there. pes anserine is sharply divided with leaving a little stump so that we can try and reattach part of it. It's very seldom you can reattach it completely, but sort of just as a scaffolding suture. The white arrow is indicating the pes anserine. The Achilles forceps, which you can just see the tip of, is pointing towards the MCL, which we elevate subperiosteally from the metaphysis. And in the image on the right, you can see a laminar spreader elevating performing the elevation osteotomy, and a large fragment cannulated screw maintaining that elevation. We pack that defect with a chamfered fibula graft, which we take from the middle third on the same leg. And then lastly, we complete the procedure by performing a metaphyseal corrective osteotomy, which is necessary in most cases. So we looked at 64 limbs in 48 children, ranging from 5.8 to 12.8, approximately 80% having an accompanying metaphyseal osteotomy. We had a 19% lateral epiphysiodesis failure, which emphasizes the importance. We were able to correct the ADMP from 49 degrees to 25. And it's important to understand this is not the arthrogram depression. This is looking just at the ossified part. So this likely overestimates the extent of the true depression. We corrected the TFA from 28 degrees varus to 1 degree valgus, and these kids with recurrence or those with leg length discrepancies had gradual correction closer to skeletal maturity. In the image there, A and B, you can see the pre-operative image and the post-operative after acute correction, medial elevation osteotomy. So that brings us to gradual correction. That's Dr. Elizarov himself, the father of the modern circular fixators. Fortunately now we don't have to struggle with these hinges, which they can become very complicated when we're looking at multiplanar deformity correction. And we now have hexapod circular fixators with computer assistance in order to correct these deformities well. Now the advantages are that the correction is not constrained by the osteotomy shape. You can see that nicely in that image on the right there. So you can translate the axis where you want it, so you don't have any iatrogenic axis translation. You can fine-tune the correction post-operatively, so you're able to adjust it, and that means it's potentially more accurate. It also is stable fixation at the same time, which is especially helpful in obese children, and you can simultaneously lengthen in unilateral cases. The disadvantages are the cost, the time spent with the patient. So they sometimes have to stay as inpatients during the correction phase. It's a cost to them to come in frequently for follow-up visits while the frame is on. And if you do have to calculate adjustment programs, it also can become quite onerous on your time. There are specific complications associated with these circular frames, specifically pin track infections. What does the evidence show? And that's basically, there's very little evidence to recommend one form of treatment over the other. However, there was one study that showed better correction of procurvatum. And I do think that's true, because that's probably when we do acute correction, the one thing that we leave behind. It's very difficult to assess that clinically on table and to make sure that you do that well. So that's I really believe that. And I think there's specific indications, and gradual correction can be very helpful. So in our practice, that is recurrent infantile Blount's disease, specifically when they've previously had an elevation and they've now short, they've got a little bit of recurrence or a failure of the lateral epiphysiodesis. If there's residual axis translation because of osteotomy done elsewhere, definitely is also very helpful. In late onset Blount's disease, obese children, or when they're unilateral and they've got leg length discrepancy as well, it may be an ideal treatment modality. I've just put lateral epiphysiodesis there because I want to emphasize that. If you've got a recurrent infantile Blount's disease, you know that most likely this will recur again. There's no medial growth potential. You need to do a lateral epiphysiodesis at the time of doing the primary procedure or when you remove the frame. And in late onset Blount's disease, there's nothing as disappointing as correcting the deformity 18 months before growth stops, and then there's a late growth spurt and the patient just returns with 10 to 15 degrees of recurrent varus, and everybody's extremely unhappy after a 6-month investment in the frame at large cost and pain and suffering. So we really want to avoid that, rather do the lateral epiphysiodesis. So what is our results? We found in 25 limbs in 19 children with an age ranging from 7 to 17, which reflects our two patient populations. A large proportion of them were obese, 76%. Distal femur guided growth were done in 2 children. Our correction duration is 16 days on median, but it ranged from 7 to 71, and that is because most of the programs were only a single program, but in 52% of cases there were multiple programs, and that's where that correction duration goes up. Similarly, in mean frame time ranges quite widely from 85 to 201 days, but we always follow the adage that you rather take the frame off a month too late than a day too early. We were quite effective at correcting the mechanical deformity parameters there with an MPTA of 86 degrees plus minus 5 and the PPTA of 79 degrees plus minus 6. And in 90% of cases, we were able to achieve acceptable alignment. This I find a very useful classification when you're looking at gradual correction with circular frames. This was published by Shyam et al. From Texas Scottish Rite. So category 1 complications resulted in no alteration required from the treatment plan, no return to OT, and it didn't have any effect on the outcome. Category 2 resulted in an altered treatment plan, but most of them will require return to theatre, but no effect on the outcome. Category 3 complications, there's a failure to achieve the treatment goals, and there may be worsening of the pathology or new pathology in grade 3Bs. So looking through that lens, what were our complications? 100% of our patients had pin track infection, so that's something that you can counsel them about. Most of those were however superficial and they only required antibiotics. 48% of them required multiple programs to correct. 4 out of 25, so 16% required return to the operating theatre, 1 for proximal ring mounting revision, 1 for iliac crest bone graft where the tibial osteotomy was done too distal from the apex of the deformity, and there was unacceptable translation, and that resulted in delayed consolidation of the regenerate, and it required autograft. There were 2 patients with deep fixation element infection that required removal and debridement. And then there were 2 category 3 complications. 1 patient was slightly overcorrected into valgus, but she accepted the deformity and she declined any further surgery. And the last patient, the grade 3B, we slightly undercorrected that tibia, and the patient fell and sustained a distal femur fracture, which does occur as well. And unfortunately, that was plated in 5 degrees of varus. So those were the 2 category 3 complications in our patients. So before I summarize it, I just want to mention something briefly to you, and this is the slipped proximal tibial epiphysis entity. This was first described in 2012 to occur in patients who are obese with these X-ray features. You can see that in the image there. They've got preserved medial epiphyseal ossification, probably because of advanced skeletal age, because of their obesity. They've got a dome-shaped metaphysis, and they've got a lateral disruption of the metaphysis and the physis. So it closely resembles the features of a slipped capital femoral epiphysis. So we were faced with this 6-year-old patient about 10 years ago, and at the time, with earlier generations of hexapod fixators without the offset struts and various other options, we thought that this was not amenable to guided growth, and we had to find a different surgical solution. We developed this osteotomy, so the transphyseal osteotomy, and that involves a large resection of a cuneiform bone fragment from the metaphysis, going through the physis proximally, removing the patella tendon, and then reattaching it, and then acutely shortening and correcting all aspects of the deformity as much as is possible while maintaining perfusion in the limb. So we went on to perform this procedure 10 more cases. 9 out of the 10 had the features of the slipped proximal tibial epiphysis. The age ranged from 6 to 9, and 100% of them were extremely obese. Our complication rate was relatively high for such low numbers, though. 1 in 10 had recurrence because we missed the physis. We went too distal, and one of these patients had articular extension of the osteotomy because we didn't appreciate the extent of the procurvatum in that individual case. So it is a relatively high complication rate. There's a significant risk of vascular compromise or compartment syndrome. So be cautious if you embark on it. But you can see this picture of this girl, and this is 10 years later after her procedure, and she's very satisfied with the outcome. So how do we approach surgical strategy selection? Infantile Blount's disease that present early, the ideal would be guided growth if they present around the age of 3. But we want to aim for correction by the age of 4 years. So if it's closer to that time, we lean towards osteotomy and acute correction. We counsel these parents about the recurrence risk because too frequently these children present to us and said they were treated at institution X or by Dr. X and the treatment failed and they're extremely unhappy. So we counsel them that this is unfortunately something that goes together with Blount's disease. If they present with infantile Blount's disease and they're known to be at risk for recurrence, and in our practice that means an MPS greater than 60 degrees or equal to 60 degrees, we counsel that they'll likely require 3 operations. The first one being this one, which is an osteotomy and acute correction with lateral guided growth. However, we know that likely the recurrence rate is about 77%, so that patient will still come back to us for a formal lateral epiphysiodesis and medial elevation osteotomy, and if it's a unilateral case, they will require the third procedure, which will be a lengthening, which we do closer to skeletal maturity. So when these children present to us late with infantile Blount's disease with an existing medial articular depression, they need a medial elevation and lateral epiphysiodesis. Most of them require a metaphyseal osteotomy as well, and you can decide whether you want to do that acutely like we do or whether you want to correct it gradually. Some authors advocate doing it at the same time, and we would suggest that you rather do this as a staged procedure. In late onset Blount's disease, the ideal treatment is guided growth if they meet the criteria. If they don't, osteotomy and gradual correction is our preference, and do a lateral epiphysiodesis, calculate the expected growth and build that into your program. Osteotomy and acute correction is, however, still an option if you don't want to go the gradual correction route. In the transphyseal slip, if you can do gradual correction, it's the safer option. If you can't, consider that transphyseal osteotomy is available. So my take-home messages: make the correct diagnosis at the age of 3 years, correct the deformity before the age of 4, assess the recurrence risk and consider strategies to mitigate this risk. If there's medial depression, you need to do a medial elevation and a lateral epiphysiodesis. Gradual correction is highly effective in selected cases. There's an increased role for guided growth, so we really need to refine this, the ideal candidate for guided growth in Blount's disease, so you need to watch the literature. I'm sure there's more studies coming out. And then lastly, remember the distal femur. It's very easy to manage this with guided growth during the growth phase so that you don't end up with a oblique joint line at skeletal maturity. Thank you very much.
Yeah, thank you for excellent presentation, and I must say that it covered everything. So now I hand over to Dr. Vidya Sagar. Vidya, please.
Yeah, sir, before we proceed, I'll just keep on sharing my slides here. And same time, can you share your experience with use of brace, which some papers have mentioned that it will be useful even up to stage 3, they say. But we lose time, I feel, using braces. Is that true, or?
I completely agree with you. I think it is so difficult to brace a knee. If we look at the problems that we've got with brace adherence with club foot, and that's a relatively easy condition to brace, I would hesitate to think what it would entail to keep a 3-year-old toddler in a brace long enough for it to be effective. I've looked at the studies and I share your take on it. I think that often there's an overlap between physiological bowing and Blount's disease, and we don't really know whether the children that have improved with the bracing protocol weren't in fact physiological and they would have improved regardless. So my take on it is I don't use it. We don't have it available, and I question whether it is a practical or feasible or affordable treatment method in our patients.
All right. Thanks, sir. I'll just start with case discussion. This is a 5-year-old girl who had bow legs since early childhood, but the right side corrected well, the left side didn't correct as expected, and the parents came with this deformity and a mild progression with time. And this is her gait video. There was no instability at the knee, either in extension or flexion. However, there was internal tibial torsion of about 15 degrees more than the other side. And there was varus, no much procurvatum. This is the X-ray when she presented to us. So which stage is this probably, if you want to put it into the Lemon classification?
So I think the problem here, and this is the problem that I have with the Lemon classification, is that it looks like the metaphyseal defect. If you look at the image on the right, it looks like it's slightly out of plane. It looks more clear on the left, and I would say this is a Lemont B. That's where I would categorize it. And if we had to measure that MPS, it would be less than 60 degrees. So it wouldn't. This would be a mild case of Blount's disease, and there are no, except the age, there are no other risks of other things, that are other factors that place the child at risk for recurrence. She's also doesn't appear to be obese.
Anyway, I proceeded. They had an arthrogram by the time they came to us. So we can see the unossified cartilage and the thick medial meniscus. And I did an arthrogram intraoperatively, and there was mild depression, but not as much as the radiographs show. So that's the unossified cartilage. And what I did was, again, lateral growth modulation, considering she was more than 4, and a RABS osteotomy, which was fixed with a screw. And this is 1 year post-op. And this was the scar. I think I used your technique here, medial proximal to lateral distal. And this is post-implant removal. And this is 5 years later. That is, now she's about 10 or 11, and no LLD, and everything is corrected well in this case. So would you do a growth modulation here in this case, or would you just skip it?
I think you've got a fantastic result, so I can't really argue with what you've achieved here. I would measure it. It's variable. I don't think with our cut-offs, I probably would have elected not to do a guided growth at the same time. I probably would have just done a tibial osteotomy in this case. But I really can't argue with your result. It seemed to have worked well, and you removed it in time. So there's no problem with its use, certainly.
Okay, yeah. So we'll go to this case, which is little interesting. So this is a 3-year-old boy, obese boy for age, early walker. He walked at about 9 months, and bilateral genu varum. They used braces, but the braces didn't work out, it seems. Otherwise, endocrinologically normal. So this is the gait he has. So they came with right side deformity. He has a mild deformity on the left as well. And this was the earlier when he was 2-year-old, and he was put in these braces. But despite the braces, they progressed, and these are made in very rural India, these braces. So compliance was very, very poor, and that was the history. And this is on clinical examination, not much intorsion really, but there was about less than 5 mm limb length discrepancy at that time, and no knee instability, and that's the amount of virus. So this, I tried to put it into classification of Lemon, but would we exactly call the right side stage 2 or left side stage 1, sorry, the Langenskiol stage, or would you have a slightly different opinion?
No, I think I agree with you. If you look at the Langenskiol classification, the description, it appears to be a saucer-shaped defect on the right, with just minimal changes on the left, and that's part of the problem that I have with that classification system. to apply that. The problem is also, and this is something we frequently see, that the X-rays are not great. So you can see that I always look at the tibia-fibula overlap, and if it's that much, it means there's quite a bit of external rotation. So you may find a slightly different picture if you get the patella forward, and then the whole classification system changes, and it changes your assessment of recurrence risk.
So that were the lines. What I did was right side classic RAPS osteotomy, and left side I did a growth modulation at the same time. This is 1 year post-op, corrected well, but later on started recurring. So again, I had to put in a screw there on the right side. This is after 1.5 years. And then 2 years later, after growth modulation, still not correcting, waited 8 years, 9 years, 9.5. The mechanical axis deviation is correcting, but I'm still waiting for the correction here. Otherwise, I don't find any plateau depression here, what we initially saw. So there was a thick cartilage which probably got ossified with time. And I think we'll be running short of time. Dhiren sir.
Yeah, let's take 3 questions by Dr. Sakti. The first question is like how internal rotation of tibia is corrected by osteotomy. Yeah, so I think that you describe in the RAB osteotomy. But Peter, yeah, what is your take on that?
So we use the curved osteotomy, and we correct the rotation acutely at the time when we displace the osteotomy. So we make a point of holding the knee and externally rotating the foot, and basically engaging that metaphyseal dome, the dome of the metaphysis of the shaft into the metaphyseal cancellous bone. So we don't fixate our osteotomies. We put them in a cast, but I mold the patella out so that I can clearly see that we've corrected the rotation. So it's part of the osteotomy and acute correction. Of course, the RAB osteotomy is a very elegant way to achieve that as well. I find it's simpler to do this curved osteotomy, but certainly the RAB is excellent. There's another South African center that are also very enthusiastic about its use. They routinely do that. So that's a great option. I just want to make an interesting point about the guided growth, and I report better. Well, I definitely need to report better on it, because Stevens has said that he believes the internal torsion corrects with guided growth as the varus corrects. And anecdotally, I have seen that in some cases. And there's also some animal studies where the guided growth plate is placed obliquely, with the proximal screw being posterior, the distal screw being anterior, and then theoretically, as the limb grows, you have an external rotation moment of the guided growth. And in animal studies, it has been shown to be a potential. So I always try and do that when I put the lateral 8 plate, to put it slightly obliquely. But I haven't critically looked at the effect of that on the rotation. It's a very good question. I think it's something we need to think about.
The second question is like whether you do a growth arrest of proximal fibula.
Sorry, is the question, do I do a growth arrest of the lateral
proximal fibula?
Yes. So at the same time, when we do a lateral proximal tibial epiphysiodesis, yes, we drill the fibula out as well. Otherwise, you will end up with a prominent and symptomatic fibula there. You have to.
The speaker is on mute.
Sorry about that.
Yeah.
So what I was saying is that you have to do when you do a lateral tibial epiphysiodesis, you have to do a proximal fibula epiphysiodesis at the same time.
So that's by a drilling.
Yes, drilling.
Drilling. Okay. Then there is a question: how you manage lateral ligament laxity in adolescent Blounts?
Excellent question. By correcting the mechanical axis of all the bones that are involved there. So I've fortunately not had a case where after correcting the mechanical axis that I have had to do anything to the lateral ligaments. I have seen some reports where people have done differential lengthening of the tibia. So you basically pull the fibula head down a little bit. That's one option. And of course, the standard lateral ligament reconstruction techniques are also available as options. I haven't had to do that, fortunately. Most cases, if you correct the bony axis and you correct the medial articular depression, you don't need to do that.
Okay, so that brings us to the end of this session. Thank you, Dr. Pieter, for sharing your vast experience with us, and you have a full range of options to offer to this condition. So thank you once again, and thank you, Dr. Vidya, for sharing your experience from India. And looking to your case, your cases are very, very mild compared to what Dr. Pieter showed. But still, that's the difference between the two countries. But really, we enjoyed it, and thank you once again.
Thank you, sir. Thank you, Dr.
Thank you.
Thank you very much to the panel, and thank you very much for everyone who attended. I really appreciated the invitation.
Yeah, thank you. Yeah, bye.